And let's talk about these. Um, so the first thing that before we even get into this question, I want to talk a little bit more about dose response curves because um, dose response curves are really, really important when you guys get to journal clubs in fifth year, especially as we're taking a look at like investigational drugs and stuff like that. So when we also as well, if I'm talking about something that is not helpful, this is the night before the exam. I want to make sure that this is like keyed to your studying. Um, so let me know. Obviously, this isn't like Orgo where I have like a very clear idea of the like my study, not my study, my lectures of like what I need to explain. Um, this so everything's a little trial and error with these classes, but um, I'll do my best. But anyways, so when we talk about dose response curves, what we have along the bottom is the dose, of course, which is in milligrams usually. And along the y-axis, we're talking about the response of the receptor. So what we mean by that is it's either the receptor being activated or it have, the receptor effect is being turned on or off. The enzyme is being turned on or off, depending on what we are adding to the body. A full agonist. Actually, before we talk about that, what's important to know is that the body has a natural amount of activation that it normally exists at. And we call this the basal activity. Basal activity is the normal amount of activity that the body would be there. So, uh, the heart cell is activated at 30%, or the stomach cell is producing acid at 30%, something like that. What ends up happening is that the effect of a full agonist brings that up way above the basal activity. So the normal activity of the cell is increased to such an incredibly high amount that we call that the full agonistic activity. Obviously, if you have a partial response to that, so if you're at some amount between the basal activity and the 100% activity, then we would consider you a partial agonist. Oop. I just want to bring up, not that, this. Whoops. There we go. A antagonist is going to keep the activity of the cell at the basal activity. So it's going to prevent the increased activation of the receptor. So an antagonist does not increase or decrease basal activity on its own. It keeps it right where it is. So if the natural response of the cell is 30%, it keeps it at 30%. The only time that you decrease the activity of the cell below what it normally is with an inverse agonist. An inverse agonist job is to lower the activity of the cell so much that it's actually below. Any questions about this? All right. Now, what's important to know about this is that we're talking about from the origin of the curves being the basal activity. But what happens if we have the activity of the cell already elevated? So if I give myself some room to talk about that. So once again, we have 0, 30, and 100. We know, once again, that a full agonist is going to increase that response all the way up to the maximal amount. The other thing to understand is that at this level, this is considered fully saturated with endogenous ligand. So remember, at 30%, we have the normal amount of ligand, of endogenous ligand. So the body, always has epinephrine floating around, always has adrenaline floating around. And so it's activating receptors at 30%. But during situations where we need to increase the response of those receptors, it increases the concentration of adrenaline in the body. And so we get that fully saturated 100% response. If the body wasn't able to increase this, we'd never be able to run away, right? So the body needs a way to be able to go from normal levels to elevated levels. We make this much better by using a full agonist. So a full agonist is able to just bypass the need to produce adrenaline by administering a drug. If you are at the fully saturated with endogenous ligand, or you're at 100% response, and you add in, oh, what color did I use? Oop, I used different color. And you have a partial agonist. A partial agonist will decrease the total response of the receptor to whatever the partial agonist's ability is, or sometimes a combination, depending on the concentrations of them. And it has to do with them competing for that active site, right? Both the partial agonist and the full agonist are competing back and forth, back and forth, back and forth. And so half of the time it's partial, half the time it's full. And so if you had the full agonist at 100% and you had the partial agonist at 55%, then the total response is going to be, somewhere in the middle. And so this is why partial agonists can act like antagonists in the presence of a full agonist, because they are competing for the same active site as the full agonist. Any questions about that, or any questions so far? All right. Likewise, if you have an antagonist will come in and try to decrease the activity of the cell back to the basal amount. Now, what's important to note is that this is very, very concentration dependent. Okay, so it depends on the dose. If you have a huge dose of full agonist and a tiny dose of antagonist, obviously the agonist is going to win, right? It's very concentration dependent, which is why these dose response curves are always, they have the dose on the x-axis. It's the independent variable. But in general, if you're going from 100 all the way down to the normal level of activity, then we are talking about a antagonist. And then finally, of course, we have our inverse agonist who will drop this below the normal level of activity. And again, the only time that we ever get lower than the basal activity level is with an inverse agonist. When we look at the two-state receptor model, where we have the inactive form and the active form, and really the way we could show this is that we have the drug bonded to the inactive receptor versus the drug bonded to the active receptor, right? We have these two different states. I'm just going to erase this so we have some more room. Get out of here. Go away. We know, based on what we've learned previously, that full agonists will increase the ratio of activated receptors, or in the active state, right? They are going to push this ratio so this side is higher. Partial agonists also push this, but the ratio, the affinity for the active receptor versus the inactive receptor is much smaller than the ratio for the full agonist. So in other words, a partial agonist has pretty good affinity for both. It prefers the active, but it's not going to shy away from inactive. Versus a full agonist is just going to go after this guy. And there's a problem later where we can talk about that more specifically. But for all intents and purposes, if it's an agonist, it's going after this side of the equation. Where is a inverse agonist going to go? Where do we think an inverse agonist is going to go? Yes, we're talking about neutral antagonists. Yep. Yep. Exactly. So inverse agonists are going to be going and increasing the ratio towards the inactive receptor. And this is why they're the only ones that can decrease the activity below the basal amount, because they are pushing the ratio further than what it normally would be. And then finally, which side would an antagonist be going after? Are they going to go after the active, the inactive state? What do we think? None? It's actually a trick question because the answer is both. An antagonist is going to be trying to restore the basal ratio. So whatever the ratio is that produced 30%, it's going to push and pull both sides to keep it where it was. So it's acting on both sides. So if you're going to go above basal activity, you are forcing the ratio towards the active form. If you're going below basal activity, you're moving it towards the inactive form. And if you are keeping it at basal activity, then you are acting on both, right? Because it's going to resist going up or down. Any questions about this information? All right. Was this helpful to go through this stuff as well? To like go through this explanation?
Cool.
Okay. Is that a neutral agonist? Neutral antagonist. Yes. Yeah. Neutral neutral antagonist are used interchangeably. It won't be until later that we talk about a non-neutral. All right. All right. Let's go through these problems. I'm gonna skip curve 1 for now, and we're gonna talk about curve 2. So curve 2, we are going from this, what could be assumed almost 0, all the way up to the maximal response. We'll get to curve 1, I promise. We have to explain the other ones first. So we're going all the way up from the bottom, all the way up to the top. So when we compare this with another curve that is going from the same origin point to a partial amount of that point, we can say that this curve is probably referring to a full agonist. And I'm just going to use consistent coloring. This curve is responding to a full agonist. Whereas if you get to this level, you are getting to the partial agonist. So a partial agonist is bringing it to this amount. So for curve 2, we can say that that kind of curve is a full agonist. Looking at curve 3, we see that it's the same sort of response, but it is shifted along the x-axis. And the x-axis is a measure of potency, whereas the y-axis is a measure of efficacy. So as you move to the right, you become less potent because you need higher doses in order to achieve the same response. So less potent to the right, more potent to the left. So we can say that curve 3 is a full agonist, but it is less potent than curve 2. Looking at curve 4, once again, we can see that curve 4 goes from 0, and it has a partial response when compared to the full agonist. So the full agonist, so this would be a partial agonist, which we know can act like an antagonist in the presence of a full agonist. Oh, did I add this in? Oh, I added this in to make it harder. That's why. That's what I did. All right. Now let's talk about curve one. Curve one is uh what's the best way of explaining this? Curve one is talking about it is we are starting at this 100% activation and moving down towards where the partial agonist response would be. Now, in the answer key, it originally said that this is an agonist. That was wrong. The Rokai, I think the I found on their Facebook that it was the wrong letter. It was not an agonist. Because we know an agonist can only increase the response. You're not crazy. Were you able to see my comment back by any chance? There were two comments, but I'm not sure if one got deleted. We'll see. Oh, okay. No worries. So what is going on here is that we are dropping the response down. So at this level, it's almost like the body has fully saturated the receptor, or that we have a full agonist going on. Now, if we had an antagonist, this would drop it down to the basal amount, right? This would go all the way down to what the basal activity of the cell would be. But we don't have any information of that, right? At least right now. An inverse agonist would drop this lower than what the basal activity is. And if it was in the presence of a partial agonist, it would have almost no difference than if the partial agonist was there or not. And I'll explain why. If we have a partial agonist present and we add a inverse agonist, it's just going to drop this level down to wherever the inverse agonist goes. So a inverse agonist in the presence of a partial agonist will start wherever the partial agonist is and drop to wherever the inverse agonist rests. So is this an inverse agonist in the presence of a partial agonist? No, it is not. Because we are starting at 100%. So where are we going here? We are going from 100% to a partial response. So this would be a partial agonist. Why not antagonist? Because remember that at extremely high doses of an antagonist, it is going to it's going to move the activity down to the basal amount. It's going to go all the way down. So as the doses increase, we see that it stops here at this partial amount, which matches the response of the partial agonist. Totally. Does that make sense for people? So we have a question about what would an inverse agonist in the presence of a partial agonist would look like. And so if we had 0 and 100, first the dose would start off at some partial amount and then would drop below what the normal activity of the cell would be. Yes, making curve 1 question 1 is cruel. Yes, that is Keel though. Yep, that would be Keel. No problem. Well, it's in a way we do have some information about where the basal activity is. And we can assume that it's somewhere down here because the full agonist, as well as the partial agonist, is bringing the activity of the cell above where the basal activity would be, the normal level of activity. So we can assume that if you reach this bottom amount, then you are going towards the basal activity. Does that make sense? So because the origin of these curves begin at a place and elevate this above, that's an assumption that we could make. What I will say is that this question could be a lot clearer about where the basal activity is. Also, I don't think these questions are made by Keel, so just keep that in mind. Exactly. Curve 1 could be an antagonist if it went all the way down, which, if we look at curve 5, it would be an antagonist. Could it be, or it could be an inverse agonist? Could it be an inverse agonist? Could it be an inverse agonist? No, I would say could it be an inverse agonist? Let me think on that. If the answer key says what? Inverse agonist, right? Yes. It does. It should go below the basal. Maybe okay. I think adding this in did make it more confusing, not just harder. So I added in the antagonist portion. So because I wanted to talk about it. But if we go by the choices that were there, we know it wouldn't be a partial agonist because a partial agonist would bring it to a partial response, right? There's also no such thing as a partial antagonist. There are a couple of drugs that do have that ability, like partial antagonism, but you are not responsible for that. So partial antagonism is not a thing, which would mean that inverse agonist is the only viable option. Sorry, that's a shitty question. If I was to write this question, I would write the answer as antagonist. This one, I'd say that curves 2, 3, and 4 are very Keelish. I think curve 1 and 5 is kind of he would make the question a lot more clear if he was going to ask you about 1 and 5. The rest of these questions are pretty fair though to Keel. He tends to go with a lot more information on his graphs than just like here's a bunch of things, at least from what I remember. All right. True or false? Drug Z is more potent than drug X, but both have the same effectiveness. What do we think? True or false? I would agree. I would say false. Big thing to pay attention to any of Keel's exams is the dreaded comma. You need to treat this comma as a big break in the question and analyze both halves of the sentence. So, is drug Z more potent than drug X? Well, we know that potency is a measure of the x-axis, and as you go to the right, you become less potent. So drug Z is to the right of drug X, meaning that it is not more potent, it is less potent. Efficacy is a measure of the y-axis, and we see that both drugs are about the same responsiveness. So these would have the same efficacy, but since the first half of the question is wrong, this is false. Three, blank displays both agonistic and antagonistic effects. In the presence of a blank, a partial agonist will act as a blank. Well, we know this second half of the question because we know, based on what we talked about earlier, that in the presence of a full agonist, a partial agonist will act as an antagonist. That is one of the big properties of a partial agonist. So we can cross off, what would that be? C and A. And so now the question comes down to, is inverse agonist displays both properties, or is it a partial agonist that displays both properties? What do we think? Bug just landed on me. That smells bad. It would be partial agonist. The reason for this is based on what we talked about earlier. An inverse agonist only decreases the response of the receptor. An inverse agonist will not increase it. So an inverse agonist will only ever go down. It will not go up, depending on what it is used with. All right. Number 4. A drug has a KD, dissociation constant, of 3 nanomolar for the active form, and has a dissociation constant of 600 nanomolar for the inactive form. Does this drug have greater affinity for the inactive or active receptor, and what type of agonist is it? So once again, we can go back to our two-state receptor model. And just to make it really clear, I'm going to use the alternative labeling, RI and RA. And so what we can say is that for the active form, it's at 3 nanomolar, whereas for the inactive form, it's 600 nanomolar. So which one of these does it have a higher affinity for? Active or inactive form? Active, right? The smaller the dissociation constant, smaller Kd, the better the affinity. So we know that it is between C and D. We know it has a higher affinity for the active. And so the question becomes, which form is it going to be increasing the concentration of? So in terms of the ratio between active and inactive, which one is it going to be pushing to have more of? The active form. Right. It's going to be pushing this side to go up and up and up. And based on what we talked about above, that if you are influencing the active form, you are an agonist, whether it's full or partial. If you're influencing and have a higher affinity for the inactive form, you are an inverse agonist. So the answer here should be C. Now, how do you tell the difference between full and partial? Yeah. Yes, you're right. That if it's 100 times more, it would be. The difference is, so, for example, let's say that we had two drugs, A and B, and we have RI, RA, and here we have the same 600 versus 3, and here we have 6,000 times 3 versus 3. So the rule is that if the ratio difference between the active form and the inactive form is greater than 100, then you would be considered a full agonist. The problem is here is that when you just have one drug to compare, we don't know. It's ambiguous if it's full or partial. So if there was another answer here if there was another one that said active full agonist, I think this would be a better answer. But because it only lists a partial agonist, I would go with C. It's the best possible answer. If you were given two drugs with both of these affinities, then we would say that B is the full agonist, while A is a partial agonist. Does that make sense? So again, not the better answer would be partial, but the better answer would be full, but yeah, based on what we had. All right. The ED50 is a measure of potency of a drug. It's the dose of the drug that produces a desired response in 50% of the population. Which part of the sentence is correct? Is ED50 a measure of potency of a drug?
Yes.
Yeah, it is. It's one of the fundamental ways that we can look at potency. So for example, if we had a dose response curve, so we have A and we have B, the only way that we are able to compare the potency of these drugs is due to the ED50, right? Neither one of these is getting to the same efficacy, which means that B is never going to reach the same level that A does. So the only way to really be able to measure potency of a drug is by looking at the half response, or the ED50. So ED50 is 100% potency of the drug. It is the dose of the drug that produces a desired response in 50% of the population. How should we? What's the question? How should we determine if he means quantal or graded response? Because technically it would be false.
That might be an out-of-pocket question. I'm sorry.
No, it's a good question. Let me think about that for a second, because it is a good question. And the answer might be that he would just have to specify. But generally we go by graded responses rather than quantal responses. At least that's how I interpreted a lot of these questions, going by graded response. Then the reason for this is because we're talking about I believe the reason is because we're talking about effective dose and graded dose response curves use efficacy. Whereas I think quantal uses like percent responding rather than percent effect. I think. Oh, let me think about that for a second. But anyways, is ED50 a response of 50% of the population? Yes, it is. Remember that ED50 is a population-based number. It is not the response of a single receptor in a single body. We had to take the response from a whole bunch of people because medicine affects everyone, not just a single person. So here it would be both. Same thing for LD50. LD50 is about 50% of the population. The effect of a competitive antagonist will shift the ED50 of an agonist to the blank, making the agonist appear to be blank potent. What do we think? Is it going to shift it to the left or the right? So let's talk about that first.
Right.
Shift to the right, exactly. So if we have a drug, and then we add in a antagonist at the same time, so we have a combination, it is going to require more doses to overcome that concentration of the antagonist. So to beat out the antagonist and before it is able to completely swarm it and give the desired response. So we see that the shift is to the right. And so whenever we move to the right on a dose response curve, we make things appear less potent. So adding an antagonist is a really great way of making your drug look worse, right? Because you need higher and higher doses to get the same efficacy. So it appears to be less potent. What would the curve look like for a non-competitive antagonist? What would the curve look like if we had an agonist and a non-competitive antagonist? Yeah. You'd have a partial response because the total number of receptors has gone down. So if you have 100 receptors and you've inactivated 70 of them, it looks like you only have a 30% response.
And so the Emax will decrease, right? With the partial.
Exactly. Yep. So a non-competitive will decrease Emax, whereas a competitive will make it look less potent. Also, would it affect the dose? I don't think it affects the dose. I think it's the same potency. I think it just affects Emax. Yeah. So a non-competitive affects Emax, whereas a competitive affects the potency. All right. Use the graph below of the dose response, blah, 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 for the following questions. All right. The therapeutic index of agonist A is roughly blank. Does anybody remember the formula for therapeutic index? Exactly. Therapeutic index is equal to the LD50 over the ED50. So looking at the therapeutic effect in red, we see that the lowest response is 0, the highest response is 100. So around 50%, we would get the ED50, and we see that that would correspond to 1 milligram. So this would be 1, and the lowest response of the lethality index is 0, highest is 100, and we see that this dose corresponds to about 1,000. So 1,000 divided by 1 is 1,000. True or false? When the adverse effect dose response curve is far from the therapeutic effect dose response curve, the drug is considered not as safe. True or false?
False.
I would agree. This is false. Whenever we talk about safety, we're talking about therapeutic index. Almost everyone is going to get a side effect of a drug. That much is known. What we care about more is if they are going to die because of the drug. And remember, the therapeutic index is made up of the LD50 and the ED50. So what we're talking about here is lethality versus efficacy. Nowhere in this equation are we talking about side effects. So it is true, however, that if the lethality index and the effective index are further from each other, you have a safer drug. So the wider the gap between these, the better. The safer the drug. Timmy has been prescribed hydroxychloroquine for his arthritis. This drug is metabolized by CYP3A4 and CYP2D6. Pharmacogenomic testing reveals that Timmy has extra copies of both of those enzymes. Oop. Timmy is likely to have. Oop, I have completely fucked this up. There we go. So we can say that hydroxychloroquine is metabolized by 3A4 and 2D6, likely into inactive metabolites. When in doubt, inactive. If we have extra enzymes, which way are we going to shunt the concentration of the drug? Are we going to shunt it towards the right or shunt towards the left? To the right. We're going to be speeding up this process and causing more drug to end up as inactive and raise the concentration of inactive metabolites. So if you are decreasing the amount of hydroxychloroquine, exactly, just like in the two-state model. So if you are decreasing the concentration of hydroxychloroquine, you are going to have lower concentrations of the drug, and it should have a lesser effect. So the answer here should be C. Any questions on this one? Sweet. CJ, he started on nortriptyline for his depression. Nortriptyline is metabolized by the enzyme 2D6. He has noticed that his medication is not as effective and goes in for blood work. His concentration of nortriptyline are very low. What can you suggest about his blood levels of the enzyme? So nortriptyline is metabolized by 2D6, most likely into inactive metabolites, which this should be your baseline assumption of all drugs, unless if you're told otherwise. So unless if you're told it's a prodrug or it's metabolized into active metabolites, just assume it goes from active drug to inactive metabolites. So if we have low levels of nortriptyline, that means that more of the drug was shunted through the enzyme and metabolized quicker. The only way to increase inactive metabolite is by increasing the number of enzymes we have. So he would have high levels of the enzyme. To answer that question earlier, Sarah, about quantal versus graded, I think only in quantal we talk about EC50, not ED50. But I could be wrong. Because it's talking about the concentration, because that has to be, but I'm not sure. I'll have to think about it. But I think that is the answer, is that they both represent the same idea, but it's a different variable. Yeah, I'm not sure. CJ decides to get the pharmacogenomic testing and receives his results back. He is a blank. So if he has increased metabolism, then we can assume that he is a fast metabolizer. Go with graded unless if it's specified. That is definitely, because graded is it is a nominal test rather than a categorical test. Slay CJ not for his depression though. We're gonna kill him. That's not a very nice thing to do to someone with depression. Okay. Mary has recently been prescribed enalapril for her hypertension. Enalapril is a prodrug that is converted to its active form via CYP3A4. Mary has very low levels of functioning CYP3A4 genes. What is she likely to find out when her doctor follows up? So we have enalapril, which is metabolized by CYP3A4 into its active form. Is enalapril active or inactive? It is inactive. It's a prodrug, which is why it requires the enzyme to put it into its active form. So if she has very, very low levels of 3A4, that means that not a lot of the drug is ending up in its active form. And so most of it is staying as the prodrug. So looking at the second part, we can say, would she have high concentrations of active drug? No. Would she have high concentrations of prodrug? Yes. High concentrations of active drug? No. Lower concentrations of prodrug, of active prodrug? No. Also, not lower concentrations. Both of those are wrong. So the question becomes, would she have the same blood pressure that she had if she never took the drug, right? Because it's basically like she just took a bunch of water or she swallowed a bunch of flour. Or would her blood pressure suddenly spike above what it was previously? Same blood pressure. Exactly. Remember, inactive drugs do not have an effect on the body, right? They're not doing anything. You might as well have just swallowed sugar. So if you don't give a drug, or if you give a drug that does nothing, you have made no changes to the body, so she should have the same blood pressure. If I gave her an active drug that actively raised her blood pressure, that would be different. So inactive things do not have effects on the body. Keep that in mind. Select all that apply. The genes for CYP2C19 enzymes are lower in patients of Chinese descent when compared to Mexican patients. Drug X is an anticoagulant that is a prodrug that is metabolized to its active form via 2C19. A Chinese and Mexican patient received a high and similar dose of anticoagulant. What is likely to be seen? So we have drug X. It is metabolized via 2C19 into inactive, so prodrug, into active form. And so when we look at this question, a Chinese patient would have less 2C19. So let's compare the effects of what's going on both sides. So over here, what would be the danger of having lots and lots of prodrug? What's the danger of having the prodrug just hanging around? Or if I never gave you a drug, what would be an issue for someone who was supposed to get an anticoagulant and they didn't end up getting it? Yeah, you'd be at you'd have a risk of clotting. Yeah, embolism, stroke. What is the benefit of having an anticoagulant? What is that going to do? Yeah, we are going to decrease clotting. However, what is the risk of having an anticoagulant? Blood is too thin, and so you have a risk of bleeding. Bleed out, die, not good. The confusing part of this question is this vocabulary, from toxicity. When we think of toxicity, what I want you to think of is extremely high doses. So if you are a Chinese patient and you are unable to metabolize, you are unable to make the active form of the drug. If you're given an extremely high dose, are you going to have less bleeding? Yes, no, yes, maybe. Yes. So if I gave you really, really high doses and you were a Chinese patient, you don't have any 2C19 to convert. So this would be true. A Chinese patient is going to have less bleeding, smaller risk for bleeding. On the flip side, a Mexican patient doesn't have this issue with 2C19, is able to make the active form, and so will they have more bleeding from very, very high doses? Yes, that is also true. Will a Chinese patient experience more bleeding from very high doses? No, we just decided it is less bleeding from high doses. The Mexican Chinese patient will experience the same rates of clotting. Well, that can't be true because we know that they have different enzyme concentrations, so they can't have the same rate of anything. The Chinese patient will experience more clotting from toxicity. Exactly. Right. The answer here is no, because is one of the toxic side effects of the drug clotting? Does the drug induce clotting? No. Clotting is where they already were. It's like the same question up here. Are we causing Mary to have higher blood pressure because she is unable to activate the drug? No. It's the same risk of clotting, We're just not treating it. We're not decreasing the risk of clotting at all. Same risk, we're not affecting it. But will a Mexican patient have less clotting? Yes, they will. So A, B, and F. Does that make sense? So the way to look at this is that if you're looking at an inactive drug, if you're looking at an inactive component, that will not change any factors about toxicity or side effects or efficacy. Inactive is inactive. So if you were at risk of clotting over here, you're going to be at the same risk of clotting over here, whether you can activate the drug or not. The only time that you can modify that risk is if you're talking about the active drug. Select all that apply. What is considered a second messenger? Yeah, I was thinking about this when I was going through it, and I'm looking at the answer key as well, and I'm not happy about it. In general, a second messenger is any molecule that carries a signal from the receptor to the effector. So in many cases, this is the receptor, so the GPCR, whether that's GS, GI, or GQ. The ultimate result is that we get to DNA, which is going to cause like protein synthesis. It's the ultimate response. The answer here is that a second messenger can be anything except an enzyme. An enzyme is not going to carry a signal. It is going to help in the production of second messengers, but an enzyme is not able to carry a signal by itself. So is CAMP a second messenger? Yes, of course it is. Same with IP3 and DAG. Both of these activate other enzymes, or they activate channels or other receptors. Same thing with calcium. Calcium is able to activate. Calcium combines with DAG to activate phospholipase C. So calcium is also a second messenger. It is part of the signal transduction. Is phospholipase C a second messenger? No, it is an enzyme. Is guanylyl cyclase a second messenger? No, it is an enzyme. Would phosphokinase A be a second messenger? No. Here's a question for you. Is the alpha S subunit a second messenger? Kind of, yes, no, maybe. Answer here. Let's look at the pathway. So we have the GPCR. We have the alpha subunit. And then we have the beta gamma, which I know they are two separate things, but I'm too lazy. And what is the first thing that once the GPCR is activated, what does the alpha subunit do? Splits apart. And what does it do from there? it goes and it activates PKA, which takes ATP and converts it into CAMP. Is this an enzyme? No. Does it go and activate an enzyme in order to ensure that the signal eventually ends up at DNA? Yes. So the alpha subunit is a second messenger. Doesn't matter if it's Q, S, or I. Does that make sense? Anyone have questions about that? Yes. Yep, that's a fair game. Yep. So would Keel ask what alpha S activates? Yes, he would. If I remember correctly, the question he asks about this is like put the steps of the mechanism in the right order. Oh, is it adenylyl cyclase? Oh, my bad. It is adenylyl cyclase. Whoops. You are totally correct. It's adenylyl cyclase. You're totally correct. Come on, guys. I did that on purpose in order to check to see if you were paying attention. Um, man. All right. If you have a question, tell me. Or if you feel like something's wrong, say it. There's a good chance I did it wrong. Which is not what you want to hear the night before the exam from your tutor. All right. 15. Which statement is false? Does CAMP activate CAMP-dependent protein kinase A? Is that true or false? It is true. So let me give myself some room here. As we talked about earlier, when we have the alpha subunit, whether it's S or I, once it splits away, it goes to adenyl cyclase, which converts ATP into cyclic AMP, which then activates PKA, which takes inactive proteins and turns them into active proteins. Right? That's as much in depth as he goes, right? He doesn't go any more than that. Okay. All right. For GQ is a little bit different by phosphorylation. Yep. GQ will activate phospholipase C, which is going to break down those phospholipids that are in the membrane into IP3 and DAG. IP3 will go to the sarcoplasmic reticulum, which I think early, like 2 weeks ago or last week, I said endoplasmic reticulum. It was wrong. Sarcoplasmic reticulum. Oh, what the fuck I was talking about at the time. Which is going to cause calcium efflux into the cytosol. So we have calcium in the cytosol. DAG will go and activate protein kinase C, phosphokinase C, protein kinase C, which calcium and protein kinase C are now able to cause a contraction, which is what the function of GQ receptors is to eventually cause a contraction of muscles. So, does CAMP activate CAMP-dependent protein kinase A? Yes, CAMP does activate protein kinase A. Does DAG stimulate protein kinase C? Yes, DAG's role is to stimulate protein kinase C. Does IP3 activate a receptor found on the sarcoplasmic reticulum? Yes, it does. But does the sarcoplasmic reticulum store potassium? No. Does guanylyl cyclase convert GTP into cyclic GMP? Yes, it does, which is part of the tyrosine kinase receptor pathway, if you're wondering where that comes from. Any questions about this? All right. So I'm going to go to 17 real quick, and then we'll go back to 16, but just because it's on the same concept. Which one of the words in the statements are false? Alpha Q activates phospholipase C. Is that true? Does alpha Q activate phospholipase C? Yes, it does. Which converts phospholipids to DAG and IP3? Yes, that is also true. DAG activates pKa. IP3 opens up calcium channels in the sarcoplasmic reticulum. Well, we know that IP3 opens up calcium channels, and that is found in the sarcoplasmic reticulum, but DAG activates pKc, not pKa. Whoever wrote that sentence is an idiot. Should have known. All right. Drug A and B both bind to the same receptor. Drug A has a KD of 0.3. Adenylyl shh, be quiet. Drug A has a KD of 0.3. Drug B has a KD of 0.2. Which of the following is true? So, first questions first. Which is bigger, nanomolar or millimolar? Which one is a larger number? Millimolar is a much, much, much larger. Very big compared to nanomolar. If you do not have your units memorized for the exam, expect to get this question wrong. Make sure you have your units memorized for the exam. Okay? There will 100% be questions about converting millimolar, nanomolar, picomolar, all that kind of business. All right? So what this means is that 0.2 millimolar is a larger number than 0.3 nanomolar, which means that the smaller number has a higher affinity. So drug A has a higher affinity than drug B. When King Henry died by drinking chocolate milk, I don't think they had what like Henry V? Oh, okay. You children. Can we say that drug A has a higher selectivity than drug B?
No,
How come?
because isn't KD a measure of affinity rather than selectivity?
You can measure selectivity with KD.
Oh, okay then.
The differences with selectivity, no, doesn't have to do with an active or inactive. The difference is that we don't have two receptors to compare with, right? Selectivity is about selecting one receptor over another. We're only talking about one receptor. So we don't have any ability to differentiate, is it going to the heart or to the brain? We don't know. We're only talking about the heart here. So selectivity requires us to have two different receptors to talk about, whereas affinity, you can talk about just one. Do we do? Yeah. True or false, a ligand binds to the same receptor that is in a different part of the body that causes an effect, is an example of an off-target based adverse effect.
False.
False. How come?
Because that would be. Sorry, bro. Go ahead.
Yeah, it would be a mechanism based adverse effect. The way I like to think about it is kind of like this, is in the body, when we have a drug, we can have the intended tissue and the unintended tissue. So in the tissue that we want, we can also have the correct receptor and we can have the incorrect receptor. Correct receptor and the incorrect receptor. If I knew how to spell. So if we give a drug, it can either go to the intended tissue or the unintended tissue, right? So if it goes to the intended tissue, it might bind to the intended receptor, the correct one, which would cause what kind of a target effect? Would it be on target or off target? This would be on target. Exactly. What about if it goes to the incorrect receptor?
Off target.
It would be off target. All right. What about if we have in an unintended tissue, it goes to the correct receptor? So it goes to the beta receptor in the lung instead of going to the beta receptor on the blood vessel. What would it be? Yeah, it would still be on target. It found the target. It just went to the wrong place. What about if it went to the incorrect receptor and in the wrong tissue? Still off target. So when we talk about these adverse effects here, what's important to know is that it's on target if it goes to the right receptor. It's off target if it goes to the wrong receptor, no matter where in the body that's happening. The reason is because that when we talk about drugs, drugs go everywhere in the body. We can't control which part of the body they go to. So the result is that you can have activation of the same receptor in many, many different places. Question for you. Is this a predictable response? Is this a predictable adverse effect? Yeah, it would be, right? Because we know exactly where it's going. We know what kind of effect it should have. And so we should be able to predict what is going on. Is this a predictable adverse event? In a, we have a new drug, we give it, it suddenly goes to the wrong receptor. Nope, not predictable. So this can be a way of looking at how drugs can end up with lots and lots of different effects, depending on if it goes to the correct receptor or not, selectivity and all that business. So a ligand that binds to the same receptor that is in a different part of the body that causes an effect is an example of off target. Nope. If it's the same receptor, it would be on target. Select all that apply. Which receptors are transmembrane? What do we think? Exactly. Everything. Whoop. As I select the wrong ones. Everything but the nuclear hormone receptor, because nuclear hormone receptors intracellular. True or false, inhibiting a reuptake in transporter would cause an increased concentration of the transported molecule outside the cell. True or false? This would be true. Yeah. So a reuptake transporter, its job is to take the molecule and put it back into the cell. If we inhibit this, we are going to prevent that drug or that molecule from going into the cell, which means it's going to accumulate outside. The Rokai one didn't specify in Kahoot. Did they use the same questions? Oh, similar ones. Okay. Choose the correct pairing of ions with their primary location. Sodium, where do we find it? Inside or outside the cell? Sodium is outside the cell. So let's make a graph. So sodium, definitely outside. What about calcium? Inside or outside? Yeah, calcium is outside. What about potassium? Inside. Big molecule on the inside. What about chloride? Outside. What about magnesium? Outside. I had to double check. No, it's inside. It's inside. because it's involved in muscle contractions. Whoops. What about proteins? Where can we find proteins? We could definitely find proteins inside the cell, right? Because they're made there. But what is also a major protein that floats around in the blood? Albumin. So the answer is both. What about phosphate? These are more just, I don't think they would be on the exam, but more because they're just important to know clinically to get them into your brain. Yeah, we know phosphate is part of ATP, so we find it mostly inside the cell. Yeah. It's all right. You don't really have to know that. Really, sodium, calcium, chlorine, and potassium, those are the big ones. So A and C. True or false, when a membrane is hyperpolarized, it is more sensitive to stimulation. So when we depolarize a cell, we go more positive. And when we hyperpolarize, we become more negative. Remember that as this is the place where the money shot happens, right? This is where stimulation and the action potential, fires, and then we have whatever action we have. So the closer we get to depolarization, the more sensitive you become. So if you're hyperpolarizing, you become less sensitive. So this would be false. The primary signaling molecule influenced by the GS-GI protein-coupled receptors is what? It is CAMP. Yes. CAMP. GTP and GTP is part of tyrosine kinase. GDP is not part of any second messenger system. GMP is cyclic GMP. And ATP is not a second messenger. It is turned into a second messenger, but it is not itself a second messenger. ATP does not go and activate anything on its own. It has to be converted first by adenylyl cyclase. Which process is most closely linked to hyperpolarization? So we have sodium here and potassium here. So to depolarize a cell, we need to have depolarize sodium influx? Yes, because it's outside the cell, and this is potassium efflux. So to get hyperpolarization, we need more of this. So potassium efflux. Blank moves substances blank a cell, while pumps move substances blank a cell. All right. So I don't know why this is a blank, because both of the answers are transporters. So they could have just put that there. So do transporters move substances in or out of the receptor? In. You transport in, you pump out. Pump out. Transport in, pump out. with the presence of an activator, what occurs when sodium ions enter the cell? The internal charge of the cell becomes more positive. The cell returns to resting potential. The cell becomes depolarized. The cell immediately hyperpolarizes. Yeah. So when we talk about sodium entering the cell, this is the same thing as saying sodium influx. So sodium influx occurs when we're moving away from the resting potential towards depolarization. So we would have the internal charge becoming more positive, and it becomes depolarized. What is the effect observed when two active drugs are used in synergy? Well, potentiated effect is where we have inactive plus active. The effect of one drug cancels out the effect of the other drug. If we're talking about canceling, then that must mean that we have an antagonist, right? So the answer here is that we have some sort of larger effect than additive. 1 + 1 equals 6,000. And then finally, true or false, ED50 is half the maximal effect in a graded response, but in a quantal response, ED50 is the dose that produces the desired response in half the population. This is true. Yes. All right. Any questions about these questions? All right. The post the questions, or 13 is tough. Yes, 13 is definitely a tough one. I don't think he would ask questions like this. Yes, I can post the annotations. Totally. Yep. The reason why I don't think he would ask this is because it is so poorly worded. All right. I want to take a look at see if I can get it back. I want to use this. What I'm going to do is I'm there is another what's it called? Another worksheet I found that has some pretty good questions and answers. The only thing is I can't find a blank version of this. I'm just looking to see if I can find it. No. Let me try this thing. No, I found this right before we logged on, so I will post this right now. Do. Nope. Okay. All right. Are there any problems from the Kahoot earlier today that people would like to talk more about? Man, these are tough questions to put as a Kahoot. How do you have any time to answer these? Ten, 8, and 3. How do you know which one is? Okay, found 3. The drug that inhibits a neurotransmitter transporter decreases the concentration of neurotransmitter in the presynaptic neuron. Oh, okay. I see what it's asking. All right. So there is a question here about what happens with a neurotransmitter when you have a presynaptic neuron. So on the presynaptic neuron, it's going to release the neurotransmitter via some vesicle. So we have our neurotransmitter. The vesicle fuses with the wall of the neuron and dumps the neurotransmitter into the synaptic cleft. Exactly. It doesn't specify the transporter. Because what did we learn earlier about the question about what a transporter is? Transporters always move substances into a cell. So we know that the neurotransmitter is dumped into the synaptic cleft, and that the function of the transporter would be to drag it back inside the presynaptic neuron. So if you inhibit this process, what would happen to concentrations of the neurotransmitter outside the cell? They would go up. And what would happen to concentrations of the neurotransmitter inside the cell? They would go down. Does that make sense? Number 4. Which one was number 4? Yes, reuptake wording. Yeah, I know. The one with RA and RI. Ah, which of the following is incorrect? Ah, all right. So we have 4 RA. We have 4 drugs. RI. So we have 10 nanomolar, 10 nanomolar. We have 100 nanomolar, 400 nanomolar. We have 10 nanomolar and 1 micromolar. And we have 1,000 nanomolar and 10 nanomolar. All right. So let's just describe what these would be. And we'll talk about them. So based on what we talked about up above, talking about the 2-state receptor model, which I am going to, am I able to grab this? Oh my God, I'm so good at technology. So based on the 2-state receptor model, what we can say is that if we have a agonist, will always have more active than inactive affinity. So looking at this, we see that for drug D, it has much, much, much higher affinity for the active than for the inactive. So for drug D, what can we say it is? Is it an agonist, inverse agonist, or antagonist? We'll talk about if it's full or partial later. For drug D, this would be some sort of agonist, right? Because it has a higher affinity for the active receptor than it does for the inactive receptor, right? It's increasing the ratio towards active, right? Ah, but, oh my God, I'm not even thinking. Yes. It's been a long day. I had a complicated patient case today. My bad. Yes, it is a larger number. So this would be an inverse agonist. My bad. See, I was testing to see that you guys were paying attention. Looking at C, same thing, right? It has a much higher affinity for the inactive receptor than for the active receptor. So this would as well be an inverse agonist. Unless nano is, no, micro is larger, right? Micro is larger? Which one's larger? Micro's larger. Micro's larger. I don't even see, I don't know my King Henry or chocolate milk or whatever. Same thing here. This has a higher affinity for the active form, so this would be an agonist. Right? Am I crazy? Okay. And then finally, it has equal affinity for the active and inactive, so we can assume that this would be an antagonist, a neutral antagonist. Now, when we look at partial versus full, we can see that the ratio difference between the active and the inactive is only 4. And we know that in order to be a full agonist, you need a difference of more than 100 times. So B would be more of a partial agonist, while C would be more of a full agonist. If we only had B and C, you could get away with saying, maybe it's like on the cusp of being full partial. It's definitely more full than it is partial. Would it be 100 nanomolar and then it would be 10 nanomolar? Yeah, that's fair. Yeah. If we converted, okay. Yeah, I guess it would only be partial. That's a good point. So it would really, yeah. I hate units. Oh my God. I don't like math. All right. 10, what was the other one? 10, 8, and 3. C would be partial. Yeah, I would say that C would be partial. But it would be, which one would have, between B and C, which one would provide higher efficacy? We don't know. You can't tell from affinity alone. Trick question. That is a kill question. Although I have to say, usually on the first exam, not enough info is provided is usually not an answer on the first exam. It will be on following exams. 10, 8, and 3. I never have enough info. I feel that. I feel that. All right. Sweet. This is where we will wrap up. I will make sure as soon as the recording posts, let me post that other thing right now. Before I forget. Any other final questions before we sign off for tonight? Yes. So for people who weren't here earlier, we're going to do an extra session on Sunday for a medchem. I'm going to post some questions for you over the course of the week to help you study. Explain polymorphism in the different mutations. actually, that's one thing that I can't really explain because we didn't go over it in my year. But let me do some searching around, see if I can find some. It'll be the same time. Yes. Let me see if I could do some searching through old notes and if I have anything from, because I think we covered it in biochem, not pharmacology. That's the only difference. All right. I will see you all on Sunday. Good luck studying. Let me check real quick. Just get that in there. And that there. Right. Yes. And yes. Okay. Let me check to see if I have any old explanation stuff. Ah, okay. So it looks like, are these his slides or I don't think Keel provides these, right? These are
Yeah,
different.
yeah, no, he just posted a bunch of sequences and then like there would be a small changes in the sequence and the letter would be highlighted red. Let me see if I can share my screen.
Oh, I know what you're talking about now. Okay. Yes. So on what would end up happening is, oh, I can give you, oh, you should have an ability to share, maybe.
Yeah, so you can see my screen. Hold on. Let's see. Uh, let me see. Let me see. Okay, right there. You're not the only one terrible with technology. I'm gonna be honest with you.
I know. I'm so bad.
Right. Okay. Can you see what I see?
No.
Okay, this is great. Démarrer la vidéo.
How about
Wait, when
now?
okay. When you want to share screen, where do you click?
There should be a button share screen down below.
Yeah. Okay. Let's see. Yeah, it's like right here. This is the one. Like he just slapped this here and he said, the normal sequence, silent mutation would be it's the same thing, but there's in one codon, there is one changing, but it gives you the same results. Then the conservative, there is another change, but it's a different result. And my thing is, it's like, during the exam, will it give us something similar to that and ask us to identify the mutation, or just give us like a case, like, there is a conservative mutation in this codon,
So
Will they-
yeah, this is actually a really good question. So I'll steal the screen back from you. What is gonna end up happening is he's gonna give you the codon chart.
Mhm.
And essentially what's gonna happen is he's going to he'll give you the amino acid sequence. He'll probably highlight the one that's different, just to help you guys.
Yeah.
And what you'll be able to see is what the original sequence was and determine what that amino acid should be, and then what the change is going to become.
Okay.
So what's like you said, so a silent mutation is that you make a change and it ends up being the same amino acid.
Right.
The missense is that it creates a different amino acid, and non-conservative would be a completely different amino acid. So instead of it being, if you remember way back from Orgo,
Unfortunately, I think I have a faint idea. Yeah.
that if you have a amino acid with a very similar side chain,
Mhm.
then that would be conservative, right? Or neutral, because
Yeah.
you're at least producing something that's going to have the same charge, maybe the same size, something like that. But if you go and you swap into a different category, you are going to completely change that protein. So an example of this would be going from, it should be valine and you go to proline, or you go to lysine, something like that. Does that make sense?
Yeah. So conservative, it's like a similar product, and non-conservative would be something entirely different.
Exactly. Yep. So similar amino acid, conservative, totally different amino acid, non-conservative. And then a nonsense mutation is that it codes for a stop codon.
And like it's just like it's out of nowhere, pretty much.
Right.
It's just okay.
And so you completely stop the gene. So
All right.
maybe instead of producing a really bad enzyme because
Yeah.
you have, you swapped out the tail, you
Yeah.
just don't make the enzyme at all. And now it doesn't work at all.
Okay, gotcha. All right,
So,
then yeah. Huh? Yeah, go
so
ahead.
he should provide at least a chart or something that allows you to evaluate if the amino acid is changing or not.
Yeah. All right. Yeah, all right. That makes sense. That makes more sense. Thank you so much.
No problem. If
Yeah.
anything comes up, send me a message either on Classroom or an email, anything like that.
I will. Thank you so much, Gabe.
No
I'll see you.
problem.
I'll see you soon.
All right. Take care.